Hi, this is John Kanelopoulos from our center here in Athens, Greece, clinical professor of ophthalmology at NYU Medical School in New York City, New York. It's a pleasure really to go through this patient who we treated one eye SMILE, the other eye LASIK. This is our publication. This was a prospective randomized study. We published 3 months, 1 year, and 2 years, and now the centration data. We'll start with the right eye. This is our standard procedure for laser vision correction, looking at OCT, pachymetry, and epithelial maps, sine fluke tomography here. Obviously, the golden standard almost globally, looking at the total cornea astigmatism, regular astigmatism here, good thickness. Placido disc topography confirms the amount of the astigmatism and also significant angle cap, as we can see here. It's the XY deviation. Axial length measurements by interferometry to confirm that the myopia is axial. And we can see here both eyes, right, left. We're going to start with the right eye, pupilometry here for both eyes. So a relatively okay scotopic pupil up to 6.7. These are measurements, autofraction, wearing, manifest, wet, autofraction, wet, and wavefront numbers. And as I mentioned, we're going to start with the Zeiss VisuMax. We'll see here the treatment parameters for this device for minus 525 of myopia, minus 0.25 astigmatism at 50 degrees. And this is a patient blinking under the VisuMax femtosecond laser. We will drape with a sterile tegaderm the upper lashes. Again, going through some basic steps to share with you our technique, which has not changed in many years. We'll put an aspirating speculum on. So we see the aspirating speculum here. Patient is a little bit of anxious here. Discussing with the patient, calming him down, helps him focus into the green blinking light that the VisuMax femtosecond laser has. And we'll rinse the first topical anesthetic. We'll rinse the surface with sterile balanced solution. And again, the extra fluid along with the secretions from the eyelids are evacuated by the aspirating speculum. A little bit more vigorous here. We can see the oily consistency of the tear film. So if the patient is squeezing a lot, we saw there was some mild blepharitis. We want to make sure that the surface is as good as possible because it will interfere with the interface, the glass interface of coming into contact with the cornea. We want to make that contact between the glass patient interface, which is disposable, by the way, one for each patient, be as pristine as possible. So spending significant amount of time, we're evaluating here the surface, the pupil. We will gently dab excess fluid and tear from the surface, and we will click onto the device to bring in the patient interface, which has previously been positioned into the laser. So there's a switch in the surgeon's view on the microscope. We're now viewing the patient's eye through the patient interface that has been attached to the VisuMax femtosecond laser. And with our joystick, the surgeon actually, instead of lowering the device to the patient, raises the patient's bed. So thus the eye is coming up towards the patient interface. I'm using the first purkinje image of the green fixation light as a target for my centration of the patient interface. The patient is asked to fixate to the green blinking light, and thus we're fixating on the vertex and hopefully on the line of sight. We can see here touch between the patient interface and the cornea, complete touch when we press the button to engage with suction. Suction of the VisuMax is milder than with other femtosecond lasers, so the patient can still see through. We see the first refractive cut performed deep in the cornea, and it's smaller in diameter than the superficial lamellar cut that will surpass the deep lamellar cut, as we can see here, and a slight side cut, the SMILE superiorly, a little bit out of our field. So the 60-degree side cut in order to give us access to the space that has been created by the femtosecond laser by the two sequential femtopasses. The first pass is the lenticular pass, which basically carves the lenticule designed to correct the amount of myopia and astigmatism treated, and then the lamellar cut is superior to that and is slightly wider, and it is at 130 microns depth. The space between the superficial lamellar cut within the cornea and the surface of the cornea is called the cap in SMILE language. So we're going to use a blunt device to define the actual SMILE cut. This is the vertical cut performed. And then we're going to go on one side of that cut and try, by pushing upwards, define the space between the anterior lamellar cut here. So here, on purpose, I'm going between the lamellar cut and the rest of the cornea, the cap, as we mentioned before. And now I'm going to go deep on the other side to define the space under the lenticular cut. So here I'm going the deepest possible, and I'm defining the space that's under the lenticular cut. And this is a very important step in order to be able to differentiate the two. It is very difficult to do this vice versa. So we're using here this hockey stick instrument to again clear the space, define the space that has been defined by the superficial femtosecond lamellar cut, which was performed second in the sequence. And you can see here how clearly I want to go all the way around and clear all the micro adhesions that may have been left behind. And now I'm going to dive deep into the second delineation I made to go under the refractive cut. So I'm under the refractive cut here, which basically now releases my lenticule. That's why I'm going from far away, equally on both sides, coming in towards my incision. I'm not freeing one side because then the lenticule will curl onto itself and be very difficult to pull it out. So now I've really released the lenticule throughout, and with one swift movement, it's almost out of the vertical SMILE incision, and with a forceps I'm going to pull out. This is an area where you may tear the lenticule and leave a piece behind, so it's very important. I'm going to rinse the interface, and we're done. And this is the beauty of SMILE. Basically, we have no open flaps. The lenticule that has been removed accounts for the correction of the amount of myopia and astigmatism. Obviously, the centration is manual, as we saw before, and there's no sacrotation adjustment. Drops, and this is the SMILE procedure in a nutshell. We will. So we're here in first postoperative day. The right eye is over 20/20 plus, good pressures. We're going to look at the anterior segment OCT, look at the cap. We mentioned before it's 130 microns in depth, pristine cornea the day after procedure. Here, the thickness maps, very little change in the cornea epithelial map, as you can see here in the 9mm optic view Avanti images. And again, this is the central cornea following the SMILE procedure and how it looks several months after the procedure. We're going to look at sine fluke tomography maps as well. We can see the characteristic very wide ablation effect. There's no ablation in SMILE, but you can see the effective change in anterior cornea curvature here in placido disc maps, and also contrastivity. The right eye is the rhomboids, performing a little bit worse than the topography guided LASIK fundus exam. Before and after is the same. So this in a nutshell is our technique in SMILE. We're going to go into a LASIK procedure now. The right eye, the left eye rather, of that same patient, same data here. Anterior segment OCT thickness maps, epithelial maps, sine fluke tomography here showing enantiomorphism in the astigmatism. The axis is almost a mirror image to the right eye. Nice sinus symmetry. Placido disc topographies here, documenting the astigmatism. We saw before the axial length measurements that we use, as I mentioned, as a key point to prove that the myopia is actual. We also saw both eyes measured here for pupilometry, and now we'll focus on the left eye on the right column. Similar myopia, our treatment here will be minus 4.75 with astigmatism. The difference here in the LASIK eye is that they will be treated topography guided. This is the alkon ZX500 excimer laser. Will treat minus 475, minus 125, 145 degrees. Topography guided meaning the device will use the topography guided data, iris recognition, and limbal architecture landmarks. Again, the Tagaderm single-use drapes to the lashes, the aspirating speculum. We can see that the view is different between the two femtosecond lasers. So we're starting with the FS 200 femtosecond laser by Alkon. It's one of the two components of the refractive suite. You can see it's a different fixation here for the patient. The patient fixates here into the white circle of these tiny lights. We're using the two red reticules that should be focused on the limbus with this specific device. And we're coming in here with first the suction cup that needs to be centered in on the cornea, slightly decentered superiorly. And now we're going to guide in the patient interface that will lock in, and we will perform the single femtosecond pass, which is at 110 microns in our protocol for many years now. And seen here in real time, it'll take about 6 seconds. So first the lamellar cut and then the side cut to create a LASIK flap. I didn't mention prior to the SMILE procedure, and any problems with the SMILE procedure, it can be converted into a LASIK procedure by just creating a side cut in the lamellar anterior cut of that patient. So it has the flexibility. If problems ensue in the completion of the procedure, it can be converted into a LASIK procedure eventually. Here we're done with the femtosecond laser intervention for our LASIK. At this interval that we're not seeing anything, the patient's bed is moved from the femtosecond laser automatically under the excimer laser, and now we're seeing our view swiveling over my chair over the excimer laser, which is just a few feet apart. And now we're focusing our excimer laser onto the flap being created. Our two red dots need to meet. That's the fine focusing, and we need to bring it over the pupil. The laser here reads the pupillary aperture. We're rinsing the surface in a similar fashion as we did before. We're using here a disposable blunt spatula attached to a bottle of BSS, and this is the only instrument I use, making this procedure completely disposable, so nothing touches the eye or in the eye. That's reused. Very important to avoid DLK. I'm lifting the flap. Very important that I'm tacoing the flap. I'm not letting the flap open onto the environment of the laser suite, so flying particles can attach to the inside part of the flap. I'm making sure here with a dry Wexel to homogenize the fluid on the surface of the exposed stroma. We're not seeing here, but there's some fine steps being performed on the laser, which tracks the pupil and tracks cyclic rotation. There's usually automatic adjustment of a few degrees if the eye has cyclic rotated in compared to when the topographic maps were obtained in the diagnostic level. And here the laser is working, treating the amount of myopia and astigmatism. And topography guided treatments, both myopia and astigmatism are treated simultaneously, and we can see it here. The flying spots, it works at 500 hertz, so 500 spots per second. I'm braking for a few seconds to homogenize again the hydration on the surface of the exposed stroma. I mentioned before that in lasers where wafer optimized treatments are used, usually the myopia is treated first and the astigmatism second. We're done with the laser ablation, and now we'll bring in the flap in place and meticulously hydrate under the flap to remove any possible foreign particles, and gently reoppose the flap. Use a drop of suspension steroid to delineate the gutter of the flap, and then use a Johnston applanator. It's a flat lens, much larger than the cornea, about 30 diopters flat. And we're using it to iron the flap back into place. You can see how nicely the gutter now delineates perfect flap position. I want that white gutter colored with a suspension steroid to be the same thickness throughout. And I'm going to use a bandage lens. We've adopted this the last 10 years as a means to protect rubbing of the eyelid with the dried cornea surface after flap creation, potential of flap movement. And this is our LASIK procedure. So basically, the two procedures are very different in the way they work. The essential goal is to, in both procedures, remove a lenticule from the cornea, which through the Mammalian formula will correct the amount of myopian astigmatism. We're seeing here the anterior segment of CT maps. See how the epithelium is different in LASIK eyes, and we reported on this with a 2-year follow-up that the pattern of epithelial remodeling after SMILE and LASIK in this contralateral eye study is different, but in essence the two procedures turn out to be more similar than dissimilar. Our initial hope with SMILE was that it would eradicate dry eye temporary symptoms, especially for female patients. We're in sign fluke images of the left LASIK eye, topography images here showing, in my opinion, better correction of the astigmatism, and this was the advantage in the study that we reported. Contrast sensitivity here, the left eye is the squares, performed a little bit better, and again, we saw these before, fundus images on both eyes. This patient remains a high myopic patient as far as the peripheral retina exam follow-ups. This is John Kamalopoulos. Hope you found this very interesting. Signing out. Thanks so much for your attention.